Greetings, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform you, but also unearth bright spots, successes at hospitals, health plans, and other healthcare organizations around our nation. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. If you've not yet subscribed to Bright Spots in Healthcare, stop what you're doing right now, click on the podcast app you like most, type in Bright Spots in Healthcare, and subscribe. YouTube, any podcast app, we're there, we're everywhere. We could brag about our star ratings, but I won't. But if you do like the show and you get value, you can leave a comment. This latest one from JIG Brooklyn, best B2B healthcare podcast, incredible ideas shared by incredible guests. Would love to get comments from you just like that. This is a great source to meet incredible guests and get access to some of their ideas and what their organizations are doing from around the country. So hope that you can tap into all of our past episodes. Today's show is going to be super interesting. It's all about how a little hospital in a little city called Boston and a hospital organization called Mass General Brigham is innovating around equitable access. And today we have with us Dr. Allison Bryant. She is the Associate Chief Health Equity Officer at MGB. I'm going to get used to saying that, Allison. A little bit about our guest today. Dr. Allison Bryant is, like I said, Associate in charge of health equity at MGB. She's working to eliminate longstanding inequities in patient care and outcomes. She is a maternal-fetal medicine subspecialist, an associate professor of obstetrics, gynecology, and reproductive sciences at Harvard Medical School, and is the Frederic D. Frigoletto, MD, Endowed Chair in the Department of Obstetrics and Gynecology at Massachusetts General Hospital. She received her degrees in biology, public health, and medicine from Harvard University, where she also completed her residence training in obstetrics and gynecology. There was a lot of words that were big for me there, Allison. I got through most of them. I screwed up at Harvard University, but whatever. That's probably why I didn't go. Welcome to the show.
Thanks so much for having me, Eric.
we're going to get into some specific examples and bright spots of programs that you guys are running over there at MGB. I want to start with a high-level question about just how does Mass General Brigham, and maybe even for those who aren't from the area, a quick 15 seconds on what Mass General Brigham is today versus what you guys were, a year and a half ago or a year ago. And just how is MGB ensuring that its innovations are accessible to everyone, particularly for marginalized communities? We were talking offline about the line of like, how do we not leave anyone behind? So maybe a high level on MGB, and then how does MGB approach all of this?
Sure, it's a great question. So Mass General Brigham is an integrated health system in the Northeast. And so it is anchored by two academic medical centers that people may be familiar with, Mass General Hospital and the Brigham and Women's Hospital, but now really is a huge organization that encompasses about 12 hospitals, many primary care and specialty care offices. So it cares for about 2 million patients and has about 82,000 strong in our workforce.
And how are you guys just overall thinking about innovations and investments in ensuring that we don't leave anyone in your markets here around the greater Boston area and Massachusetts and New England in general? How do we not leave anyone behind?
Yeah, it's a great question. I think what we've tried to do is to be super intentional about this work. And so we are moving forward sort of our work in terms of improving quality across our organization. And what is foundational is that there is no quality without equity. So we know that if we are not caring for all of our individuals, we can't be claiming to provide quality care. And so some of this work is really foundational under our United Against Racism campaign that was stood up in 2020. That includes a lot of foundational work. So things like data accuracy. We can't improve what we don't don't measure, so if we don't capture race, ethnicity, language, sexual orientation, gender identity appropriately, we can't make those improvements. Thinking about digital access, which I'm always happy to talk about, language access, and things like social risk-informed care. So understanding who our patients are, understanding what our patients need, and then building our structures to make sure that they are centering on equity for everyone.
Great. And we're going to get into the UAR, United Against Racism overall strategy, because that's spawned a number of really interesting programs that I want to get into. Before we go there, because you mentioned super intentional and no quality without equity, how do you think about getting leverage through into the communities that you serve, so many, right? 2 million patients, I think is what you said. So could you discuss just, and maybe even provide an example if you have one, about a partnership between MGB and the community that's maybe resulting in some positive outcomes and increased access to care? And then we're going to kind of shift into some of these programs that UAR has spawned.
Yeah, incredibly important, because I think we see as our mission both improving the equity of outcomes of patients who consider themselves MGB patients, but also we are beholden to the communities in which our buildings live. And so we've done a lot of work about thinking about community health equity as well. So thinking about our community health needs assessments, what do the communities feel is important to them? How do we focus on getting best outcomes there as well? Part of this partnership is really thinking about our hybrid space. So taking our high quality care that we provide in our brick and mortar sites and delivering that in our communities. So one example of that we may talk more about is our mobile care units or our community care vans. And so those are spaces where we collaborate very intentionally with community-based organizations like, for example, La Colaborativa in Chelsea. So a community-based organization, we understand their priorities, they understand our priorities. We work together to co-design times that the vans might be in their centers. They send us patients. We make sure that we provide social risk mitigation and social risk informed care to all comers, right? So patients who identify as MGB patients, as well as patients who come from the community of Chelsea who wander along and get hypertension care in our vans. So really being intentional about community partnerships is definitely central to the work that we do.
I like that. By the way, my grandfather on my mom's side from Chelsea spent a lot of time there as a kid. So can you give me a little bit, maybe share some ideas around that program that may or may not make it unique? A lot of organizations are trying to put mobile care into the communities, some of it without success, some of it with marginal success. Can you give us a little bit of a purview into, maybe even explain for folks who aren't from the area, Chelsea, first of all, and then maybe and the dynamics in that town, and then maybe how that program is working and why it's working the way it is?
Sure. So Chelsea is a community that is just north of Boston, so connected to Boston by the Tobin Bridge, and is an incredibly vibrant community with lots of resilience and culture, a very diverse community, a community that has lots of socioeconomic diversity, but also has its health challenges. So certainly in the early days of COVID, Chelsea was one of the sort of epicenters of the epidemic, and yet very quickly became sort of the city that had the greatest rates of vaccination. So really a health conscious community, but also affected by many social determinants of health that we need to address. And so in terms of our mobile work, one thing that makes it unique is that I think many places have thought about bringing screening out into communities, right? So bringing mobile platforms to do blood pressure screenings or diabetes screenings, which are incredibly important. But what we have really tried to move the needle on is actually providing clinical care in those vans. So yes, you come in with an elevated blood pressure, but now I also have a licensed clinician on that van who can change your medications or talk to you about health education, or send a prescription to your pharmacy and then provide some of that longitudinal follow-up. In all of our health equity work, we're incredibly intentional about thinking about the clinical outcomes. So it's social risk mitigation, not just for social risk mitigation's sake, but also to achieve equity in those clinical outcomes. We're holding ourselves accountable to what is the most recent blood pressure, what does the hemoglobin A1C look like, even if, and especially if your care is provided in one of our mobile units.
Okay, I have a couple of follow-ups. This is super. It sounds to me, and tell me if I'm misinterpreting, that you've almost, because of your history in that community, have established almost this culture in a good way of receiving care through mobile, through vans, and so it strikes me that we need to ask the question, because we know historically, especially in underserved communities, this chasm or almost distrust between healthcare and the healthcare world and certain communities. So how did you establish that culture of mobile care in Chelsea? And was there any secret sauce to it, or is it just consistency? Like, how did that happen? And two, is there any way that you're able to provide any sense of longitudinal care for, let's say, someone with diabetes?
Yeah, it's a great question. It's hard to imagine that COVID was ever the secret sauce for anything. But I think in this particular instance, the mobile work really grew up out of the need to be able to provide just in time, very local COVID-based care. And so the mobile work that we started was initially with some grant making that was done to provide mobile services that initially were doing COVID testing and then COVID vaccinations and ultimately COVID therapeutics. And so that was incredibly successful in this community. As I mentioned, that was initially very hard hit with COVID, but also very interested in vaccinations when they became available. And so we launched that work in 2020, 2021, and then really have morphed it. So as the need has decreased for COVID-based care, we said, why not use that platform to think about the other health priorities that are so important to us? So thinking about cardiovascular disease, so hypertension is one of our really main prioritized conditions. We're also providing substance use care on our mobile platform, and we'll be transitioning to provide some maternal health care because those are three of our pillar prioritized outcomes. And so there are, plenty of stories of individuals who get their care in the van, happen on the van with uncontrolled hypertension. The van team is fantastic. And one of the things that's fantastic about them is they really have a community health worker on the van. So screening for social determinants of health, understanding that your food insecurity, your transportation insecurity may affect your outcomes and trying to mitigate those, and then being able to be that longitudinal care provider as needed. Our ultimate goal is to transition people and provide warm handoffs back to brick and mortar primary care, but that doesn't always fit everyone's need. And so if they're not able to get back to their healthcare provider at the Chelsea Healthcare Center or back to Boston, our vans are there. They know at predictable times that they can come back to the van, get their blood pressure checked, get their hemoglobin A1C checked, and get those things managed in that mobile setting.
I love that. And the team, so it has a CHW. Who else makes up the van team?
So each of the vans is led by a medical lead. So there's an MD provider who's always available to the van, but may not be on the van at all times. There's always a nurse practitioner who's providing the clinical care on the van. There's a medical assistant who's there to register patients, get vitals, do social determinants of health screening in addition, a community health worker, as we mentioned, and then there's an operational lead who really is helpful to get everybody where they need to be, making sure that they are collaborating with the community-based organizations where we're going to park all those other fantastic things that keep the vans running.
Do you pick people from the area initially? Like how does that trust initially build up?
Yeah, I think that that's an incredibly important part of much of the work that we do. So as we think about who's going to be on our care teams, we really do prioritize having individuals who have knowledge of the communities in which we will serve, because having that trusted relationship, knowing, the local environment is incredibly important to us. So certainly not every care team member comes from the community in which the vans go, and also the vans are interchangeable around the greater Boston area, but really having sort of that community presence is incredibly important, as well as the relationships with the organizations that have been embedded in those communities for years and years.
Okay, I like that. So just to summarize, and we'll put a bow on this for a moment, the program focuses on hypertension, substance abuse, and maternal care as the three pillars.
Correct.
It sort of spawned out of some of the necessity during the pandemic. You have a team in the van that's made up of a CHW, probably from the area, a nurse practitioner, a medical assistant, an operations lead, logistics lead, and then a doctor may or may not be in the van, but available, I'm assuming, through telephone or video.
Exactly. And we have these new tricked out vans, which are fantastic, that have the capacity to actually provide telemedicine care. And so, for example, if the van is out for a hypertension day, but we encounter someone who needs their substance use managed, if there's not a provider on the van who's able to provide that care, we could, do a telemedicine visit back to our brick and mortar clinics as well.
It's awesome. And I hesitate to ask this, but I know if we're going to convince people to consider upping their mobile game, their mobile van game, or their mobile bus game when they're listening, how is this funded?
So initially, the initial funding came through a philanthropic grant for the COVID work, but really because we've shown success, we have melted it into our operational budget. So it is paid for by MGB operational funds through our offices.
Got it. Awesome. All right. I would love at another time we could dive into the ROI model there, but I think I want to move on for a second because I want to get into some of these other specific programs because they're so exciting. Before we do that, what strikes me is maybe I want to get to know Dr. Allison Bryant a little bit better. So you've obviously you're invested in this. You're in a leadership role at a prominent hospital. How did you get there? What's your personal connection to healthcare to begin with?
I don't know. I come from New York City, which is why I talk real fast. I don't have any doctors in my family, but I loved my pediatrician and always thought that I was going to be a doctor, thought I was going to be a pediatrician, but ultimately really fell in love with women's health care and with pregnancy care, and so pursued OBGYN. Um, I think I always knew that inequities existed from the clinical care that we provided. At Mass General Hospital, there was a campaign for everyone to describe their sort of aha moment when they came to understand the role of health inequities. And for me, I have in my office an issue of the Boston Globe from 2002 that said infant mortality of Blacks on the rise on the front page. And that resonated with me. That was something I'd seen clinically, but didn't have didactic training around. And so that's what really sort of, I think, lit my fire to sort of understand this, understand how healthcare policy is made that impacts these communities, and ultimately shifted my focus to thinking about infant mortality to maternal mortality. I work on the Maternal Mortality Review Committee in Massachusetts, and really sort of digging into some of those inequities. And so from there, it was a sort of logical path to think sort of moving beyond just maternal health care, even though we've certainly not solved all of those crises, but to thinking about healthcare writ large in the role that I'm currently in. I also think it's deeply personal, right? I'm raising two biracial sons. I come from a family that has had its own challenges in terms of health inequities, despite who I am and the work that I do. And so there's inequity everywhere. Like, Black individuals are more likely to be suspended in my kids' schools. And so there's no space in which I sort of walk in that there's not inequities that I feel like my skill set might not be able to help.
I actually you struck a chord because one of my hot topics that we covered recently, I had a woman by the name of Angela Thomas on the show from MedStar down in Baltimore about their program Safe Babies, Safe Moms, and it was all about equitable access and maternity care. Great episode for those of you listening if you want to go back and find that, Angela Thomas. But yeah, I think it's crazy how maternal care is so disparate, and the numbers are just staggering. So yeah, love that you're doing all this work. What is something, as you put your executive hat on for a moment and your innovation hat on, is there something that you believe around our healthcare system that other people may think is a bit crazy or out there that you want to share with us?
No, my initial reaction to that is that I think that left-handed people are superior and will rule the world someday, but that's my own personal delusion, and that's fine. I think separately, I think it's important to say out loud that I truly believe that everyone has the right to healthcare and has the right to their optimal health outcomes. And that, I think that we are in a prized position living in the Northeast in a healthcare system in which I think all of our executives believe that, but I know that that's not the case everywhere. Just gave a talk sort of at a national meeting where I talked a little bit about our Massachusetts health equity initiatives and our payers health equity initiatives, and poked holes in them a little bit, but recognize the privilege that I have to do that, because that's certainly not the circumstance across healthcare in the United States, is that I don't think everyone has that same fundamental belief that we should be vanquishing health inequities, that health inequities don't have anything to do with the individual person or their own biology. And so I will stick to those beliefs until the day that I die, but I'm not sure that they are shared across my entire industry.
Yeah, it does strike me, and maybe we could cover this a little bit later on in the conversation. Like, we do a lot of topics in and around this discussion that we're having, and when I get to meet heads of health equity, and before we go sort of put the recorder on it, so to speak, there is just lamenting about, like, it's a focus, it gets a lot of attention, but the funding isn't always there. So there's a lot of talk, but maybe not as much walk, and even in the Northeast. And so I guess at some point I may poke at that a little bit and get your take on that, Allison, because I do think even in the Northeast, we struggle to rationalize the funding if we can't see sort of the short-term business case for it. I guess then one last question before we move on again to some of the programs. Is there anything, in your adult life that maybe would be seen as a failure or an apparent failure that later set you up for success and sort of got you to where you're at such a important, influential point in your career today?
Yeah, it's a great question. I'm gonna have to dig in on that one. I don't know. I think I've had to make some choices in my sort of overall professional life. So maternal-fetal medicine is a specialty that has a lot of different facets to it. And so in some ways, there's the fetal side, there's the maternal side. I wouldn't call it a failure, but I think that I've always been much more of a maternal health-driven person. And so that means that I sometimes have had to sort of leave some parts of maternal-fetal medicine behind. And that sometimes makes me feel like less of an MFM, but I think that it has driven me to sort of really focus on pregnant individuals and the threats to their health equity that has sort of spawned this sort of interest. So I think in some ways sometimes I think of myself as being less of an MFM, but I think that that's actually not true.
Well, that's a perfect segue. So let's delve into this doula program at NGB and maybe share a success story or an impactful outcome from the program that highlights sort of its effectiveness and promoting it and promoting better health.
Yeah. So we have, as you referenced, a doula program at Mass General Brigham that was born again out of this United Against Racism work. Much of our work under UAR, as we call it affectionately, has to do with primary care. So, right, things like hypertension, substance use disorder, because those things are so foundational. But I think we recognize that there are inequities in every single field, every single specialty across our enterprise. And so UAR has offered funding to each of the specialty departments across the organization to think about an inequity in their field. And the doula program was born out of a fantastic collaboration of OBGYNs across our enterprise to think about C-section rates amongst Black individuals in particular, and what might be an evidence-based way of reducing those C-sections. And so what we've done is to stand up a doula program to think about those individuals that are at highest risk of needing a C-section, to think about whether we might be able to mitigate some of those risks by providing doula services free of charge, collaborating with doula organizations in the community, so we don't employ the doulas ourselves, but inviting those doulas into our spaces, paying for them so that people don't have to pay out of pocket, and allowing people to interact. And so it's been a fantastic experience, both to help to design the program, to implement it, and then to see it bear fruit. I myself, as a practicing obstetrician, have had many patients go through the doula program. I think in particular about a patient who was pregnant, obviously, was less supported during her pregnancy by family members and others than she anticipated that she might be. And so, was going to be going through labor and delivery alone, had lots of fears. There's so much in the lay press around Black maternal mortality. And so she was very worried about what was going to happen to her on labor and delivery if I couldn't be there. And that she had the supportive doula at her bedside that knew her preferences, knew how to help to advocate for her with the clinical team, really, I think, helped her to have the best experience that she could have. And so I also think our clinical care teams are really quite impressed with the relationship all around. And so that's really what we want from the doula program, is to be that bridge, that professional support person between our patients and the clinical care teams to try to drive health outcomes.
So let me summarize that a bit, because I want to make sure we get all the components. One is these are 1099s. Second thing I picked up on was you guys are paying for them, so you reduce any payment friction. Is this targeted at Medicaid / non-exchange members, or is it anyone?
It's not targeted by insurance. It is right now restricted to individuals who are having their first baby. So we're trying to lower the risk of what we call NTSV C-sections. So null-purpose people having their first baby, having one single baby at full term with a baby that's head down, which is basically a group that should be at fairly low risk of having C-sections. And so that's our restrictions right now.
Okay, got it. And how are you, like, if the fundamental KPI is reducing C-sections, can you share with us sort of some of the results? And then I'm curious why you think it's working so well or not.
Yeah. So I think overall, we're still in some of the early phases. Preliminary data would suggest that the C-section rate amongst individuals who have had and accessed doulas seems to be lower than the overall C-section rate. It's not a randomized clinical trial, so I can't tell you that those two groups were exactly equivalent. And maybe there's something about individuals who would choose a doula that would have a lower C-section rate to begin with. So I don't want to overstate that as a conclusion, but both patients and providers and nursing staff seem very happy with the program. I think the question about why it might be working is just goes back to the fundamentals about why in randomized clinical trials, doulas have been shown to decrease C-section rates. And I think it has to do something with the sort of communication that happens at the bedside. So these are individuals who come in with the intent to be laboring, with the intent for a vaginal delivery. We know that definitely there are clinical indications that they might need a C-section, but some of that may be influenced by the communication, by the advocacy of the patient and their family to the clinical care team, that some people might be given more time, or maybe we interpret the fetal heart rate tracing slightly differently. And maybe the doula is that bridge there that helps to do some of that advocacy and that sort of, advocating for patients if we can safely accomplish that. So that may be the secret sauce, but I don't know that we've ever figured that out.
So it sounds like, and I don't want to simplify it too much because obviously it's all in the execution, but it sounds like it's taking what is, I'll call the traditional evidence-based impact of doulas and almost promoting the doula as a resource to the patient community and using them more readily than maybe the traditional patient walking into MGB would even be familiar with, as a mechanism to reduce C-sections and overall costs and improve outcomes. Is that, am I simplifying it too much, or?
No, I think that that's fair. And I think the thing that's different is just that, in the traditional model previous to this, it had been very much a sort of pay out of pocket model. And so individuals, even if we're not stratifying by insurance, individuals who might not otherwise have been able to afford a doula now can get a doula free of charge. And so one of the fantastic innovations that's happened since then is that Mass Health, our Medicaid product in Massachusetts, now has doulas as a covered service as of earlier this year or the end of last year. And so that we think is really going to be helpful across the entire state to provide financial access to doula care for individuals.
Now, is that how it gets financed, or were you guys picking up the tab initially?
No, we are picking up the tab initially, and we continue to pick up the tab. Now that there's a shift that some patients may be able to access that through a different funding source, it means that we may be able to shift our focus to more commercially insured patients who may still not be able to afford the cost of a doula, because Mass Health will be able to cover the individuals who are publicly insured, but we are paying for the doulas for the patients in our program.
Okay, so if there's someone, let's say a CEO of a 100-bed community hospital 2 hours from Dallas, Texas, that may not have the Medicaid coverage and may not have the resources of a tertiary network like MGB, how should they be thinking about this program and financing it?
So I think that those are really the only two options right now. So it's really either whether it's going to be a covered benefit by public insurers. And I'm hopeful that there will be a movement, right? So that the public insurers may start to cover it, then the commercial payers may see the benefit and may sort of widen their networks. There are sort of pockets of commercial insurers that will cover it. And so I think that hospital administrators should look into what's available in their environments to understand where there might be some specialized pockets of coverage. But otherwise, doulas are not expensive. They're a resource that we need to pay for. So I think there's not really a substitute for what a doula does. And so it's really important to think about what that financing stream would look like. We paid for it out of operational funds, and we'll continue to do that for the population that has need.
Okay, I want to shift gears from inside the hospital or the clinic and talk about sort of virtual care and digital healthcare. And when we were preparing for this conversation, we were talking about a term that you introduced to me called tech equity. Fascinating topic. So how does MGB ensure equitable access to digital technologies, and maybe share an example for everyone about how this approach is positively impacting outcomes?
Sure. Maybe in two ways. So one is really to think about sort of the foundational work in digital healthcare. So, one thing we learned during the pandemic is that we were using much more often our patient portal and our electronic health record as we were doing digital care. That patient health record was all in English. And so if we think about the combination between language access and digital access, we went through the extra, quite expensive step to translate our static content of our patient portal into the top 6 languages that our patients speak by employing a team of fantastic medical translators. And that's become our standard, right? So if we're going to give you a patient reported outcomes measure questionnaire, that questionnaire is going to be translated into one of our top 6 languages. So that was 1,000 questionnaires that were translated by that team. So that's kind of foundational floor work, because if an individual can't read the thing that you are offering them, then your whole digital platform is sort of blown up.
So, Allison, let me ask you a quick question there. So, is that just for the intake, the initial intake, or is that for the entire patient portal experience, the gateway experience, or is that just for the front end of it?
It is for what we call the static content. So it is basically everything in Patient Gateway is translated. So everything that you might see when you open up your Patient Gateway, if you are a patient in whom we've identified that you are a native Haitian Creole speaker, everything that you see in Patient Gateway that is content that we have written should be in Haitian Creole. That will also include if you come into OB care and I want to deliver to you messaging around OB care that is centralized, all of that patient-facing content should be returned to you in Haitian Creole. The issue that we run into is just the dynamic construct, right? So Patient Gateway is got a function where you are going to write me a note back and forth and I'm going to communicate with my nurses or whatever. That has been harder to actionably translate in real time. And so we're trying to work on solutions for that. We knew that if we put things out there in people's languages, then people would come and start to use it, which is exactly what we wanted to do. But that feature, sort of the in real time, you send me a note that says, I'm having contractions, and you send it in Haitian Creole, getting that turned around to you is challenging to do. So we're working on many kinds of solutions and thinking about ways that we could fix that piece of it.
Okay, a couple quick follow-ups on that. First of all, Patient Gateway, sorry, I brought up that jargon.
Yeah.
That is the name of the MGB patient portal.
Exactly.
Second, can you, what percentage of the 2 million that you cover is covered by those 6 languages? How many people were kind of like, just curious, because I want to circle this back to the audience. So if they're thinking about like the 80-20 rule and where to go, because let's not let perfect good. It's not be perfect. Could be the enemy of
that one.
Could be the enemy of good. Yeah. So one, how many people aren't covered by those 6 languages, and then secondly, how long did that take?
Yeah, great question. So I think that of our 2 million individuals, and again, different by geography and other constraints, probably about 8 to 10% of individuals prefer a language other than English. Of that 8 to 10, I would say probably a good 80 to 85% are covered by those top 6 languages. So we still are committed to being able to communicate with those individuals who speak non-English, non-top 6 languages. And so we have other ways of thinking about verbal communication and contracting with other individuals who might be able to provide verbal interpretation. But in terms of the standard translating written materials into those languages, we feel like we're covering a fair bit of the need. And so that project to sort of translate all of Patient Gateway probably took on the order of 6 to 9 months, if not more, and is ongoing. So as new materials being developed, right, a colonoscopy prep that is the entirety of Mass General Brigham has agreed on a single English document, that document then gets translated. And that turnaround time is getting rather quick. We've got, again, a fantastic crew who's using a lot of good digital solutions and tools to translate materials. That turnaround time is actually quite fast.
And quite fast is?
Probably on the order of 2 days to say maybe a 1 week, depending on what the other priorities are. So again, in the time of COVID, we certainly escalated the turnaround time for many of those documents, and things that were more routine might have to wait. Now that we have less of those sort of flaming hot translations that need to be turned around within 3 hours, we can sort of be a little bit quicker on the ones that are more routine.
That's great. So my quick math here, when you say about 10% prefer something other than English and you have 85% of those covered, is you essentially have, 91.5% of your patient population are covered by native language. I think if my math's right, 8.5%, maybe not yet.
Yeah, I think that's fair.
And so what would, so now that you've done that, like what other sort of digital equity programs do you have sort of coming out of UAR?
Yeah, so that work on translation is really the foundational work. I think what we recognize for sure is that there is a digital divide, and not all individuals are equally comfortable using digital tools. So things like patient gateway and how do we communicate back and forth, but also things like I'm going to send you home with a blood pressure cuff, and I want you to be able to download your blood pressure so that your primary care provider can see them. And so one of the early programs out of United Against Racism was called our Digital Access Coordinator program. And that is a program that is a workforce of multilingual community, individuals from our communities who provide at the elbow digital support to individuals. So, a patient who speaks Russian, for example, who has trouble signing up for Patient Gateway may be assigned or referred to a digital access coordinator that provides either in person or virtual, if we can make it work, enabled support to maybe get someone signed up for Patient Gateway, make sure that they know how to use it, make sure that they know how to use digital tools. And so that really has been quite a successful program with a lot of, fantastic patient feedback. We've enrolled many, many, many patients in Patient Gateway. I don't have the number right now in front of me, but now we're moving on to different metrics, right? So yes, we can enroll you in Patient Gateway, but once we've done that, what is your likelihood of engaging, of sending back and forth messages or checking your labs? And so those are metrics we're starting to dig into now. And the other thing that we're thinking about really in terms of the digital world is that sometimes we are reactive, right? We've built something that is great for the masses or for the average patient, but we haven't really kept equity at the center. So just next week, I'm going to meet with digital leadership about thinking about, as we roll out anything in the digital space, how do we make sure that equity is centered? So the thing we're building, the thing that we are inviting in, the vendor that we're inviting in has got language at their center, has got thinking about sort of all levels of digital literacy at the center. So we're really trying to be much more intentional about designing programs that are going to meet the needs of all of our patients.
Okay, so couple of questions here, follow-ups. The digital access coordinators, one, how many are there to be able to be at the elbow, as you call it? That seems like, how is that scalable and how is that financed?
Yeah, so again, this is all financed through operational funding. That was a program that was never funded externally or philanthropically, so it was built into the overall operational budget of United Against Racism, and now it lives in the digital side. Right now, we have about 8 FTE of digital access coordinators, and so it might be a few more than that. It's 2 different models, one of which is really embedded in primary care practices. So those practices that have are what we call United Against Racism practices that probably have the highest prevalence of non-English speakers, individuals who identify as Black, Latinx. There are digital access coordinators who speak languages who are embedded in those practices, so that the front desk may identify, here is Mrs. Jones, she's not enrolled in Patient Gateway, there's the digital access coordinator, please go see her, and they will help to work together. And then there's a crew that is sort of centrally based, because Mass General Brigham is, it is diverse in terms of its geography, and we can't embed individuals in every practice, but someone could file a referral to the central DAC folks who might be able to then reach out by phone, set up a visit to help to walk people through what their digital needs are.
Okay, so around 8, we'll play around with the number 8. I know you weren't sure, could be a little higher, but 8 folks, so roughly 4 or so folks sit in primary care practices, which seems to make a whole lot of sense. And then a certain subset of those folks are sort of like almost hospital-based, centralized based.
Correct. And so, and the other, there's a couple of other pilots that we're working on, but things like, should we have a digital access coordinator in an emergency department? So we have one right now stationed in the MGH emergency department. We're doing much more inpatient digital screening. Should we have one that roams the hospital and is available to inpatients, right? As we send you home, and I want to send you home with a virtual follow-up visit, how do I know that that's a reasonable and safe thing for you? Should I have a DAC come to your bedside and make sure that you have what you need?
Awesome. I love that. Now, so I understand UAR gets funded. You decide this is an important initiative for the long-term success of the program. Makes sense. But what are like the business metrics that if someone was going to take just this program in their community and just this program out of the, borrow it from UAR in Boston, what are the business metrics that could rationalize this kind of investment?
I think what we really try to hold ourselves beholden to is clinical outcomes. And so we sort of have had this framework of the Donabedian model of structure, process, outcomes. And so we have made a bunch of investments in structures and hold ourselves to accountable to, did we build the structure? So for example, for our bridge clinics, which are low barriers to substance use disorder clinics, we built some more bridge clinics. Were we able to do that? Check. Did patients come to those practices? Check. Now we're moving on to thinking about process. So are we, through those clinics, able to bump up buprenorphine prescriptions, for example? And can we do that in communities that have historically had lower rates of prescription of buprenorphine? That will be a process metric. And then ultimately, we'll be thinking about things like outcomes. So what is the rate of overdose? What's the rate of overdose mortality in those communities? And so our business case really is our clinical outcomes case. And so ultimately, we are driving towards improvement in clinical outcomes, which is why we have been so closely hewing to our prioritized health conditions. Because I think we recognize we can't really do it all. There are inequities in everything. And right now we need to be laser focused on a number of clinical outcomes and hold ourselves accountable to those.
Okay, so you said it's structure, process, outcomes.
Mm-hmm.
And what's that methodology you referred to?
A Donabedian. So the Donabedian of quality improvement sort of starts with building the structure, then looking at process outcomes, so things that may not be hard clinical outcomes, but demonstrate that you were on the path, and then holding yourself accountable to the ultimate clinical outcomes at the end.
So build the structure, process outcomes, clinical outcomes. Awesome. We'll put Donabedian.
Donabedian.
Yeah, we'll put that into the show description for everyone. That's awesome. Anything else around digital support or just tech quiddity that you want to share? Another initiative?
No, I think the other space that we are really sort of looking at, and we're just not sure is ready for prime time, is artificial intelligence in terms of thinking about machine translation. So, I think as we talked about that need for sort of real time, when you're leaving the emergency department and I need to send you with discharge instructions that are customized to you, if I keep you in the emergency room like 10 minutes longer than otherwise, then that's a huge cost to our emergency departments. And so we really are looking into how can we get safe translations of some of that material, and is artificial intelligence sort of ready to meet that challenge?
Great. And as far, I've been asking you a lot of follow-ups here around impact because I want to inspire folks listening to think about innovations like this at their organization. And so is there any methodology, beyond what we just discussed, and maybe we just covered it with the Donabedian kind of for quality improvement methodology, that you think about that you could advise folks to look at for measurable impact? And maybe you have an example of one so that, I guess put it another way, like how are you measuring the effectiveness of your investments in health equity initiatives? Is it through this methodology, and maybe provide one example?
Yeah, it's a bit through this methodology. And then I think with the additional, the Donabedian model is really about quality and process improvement. And so we have the extra burden, privilege of making sure that works for equity. And so we want to be intentional about how we measure that. I think one example is our work around hypertension. So we really have gone all in on social risk informed care planning. So again, hypertension, a silent killer. Individuals don't feel their hypertension, but we know it's a driver of death, and it's a driver of excess death in Black and brown individuals. So our work in hypertension is really thinking about who has uncontrolled hypertension in our practices, assigning them a community health worker to help address any social needs and make sure that they have the tools that they need, and then continue to rigorously measure their blood pressures. So one place, if we think about what outcomes look like, is our initial outcomes that we were adhering to were, let's just bring the rate of uncontrolled hypertension down in affected individuals. So for Black and Hispanic individuals, our metric in a given fiscal year was, let's lower that rate of uncontrolled hypertension in those populations. We were able to achieve that. The next step really is then reducing the gap between the high performers and low performers. And that's really hard to do, right? So we want everyone to be improving, but we want our Black and brown individuals to be improving out of proportion to other individuals, so we close those gaps. And so that is sort of a framework that we are using, is in that structure, process, outcomes. The first outcomes that we're going to look at is, can we improve outcomes for the marginalized community? But secondly, can we close those gaps? And so that is what we're working on now in terms of hypertension and our substance use disorder care.
A couple of follow-ups there. So first of all, I want to confirm I heard that right. Social risk informs planning?
So risk-informed care planning. So I can develop a care plan for you around your diabetes, but if it doesn't take into account your social need, we're not going to get anywhere.
Understood. And when you say improve the outcomes for marginalized communities and close those gaps between high performers and low performers, are you saying that within the marginalized community, or comparing the marginalized community as the low performer versus another community?
The latter. So in that particular instance, I was talking about, our gaps. Data-driven gaps are between white individuals and Black individuals, and non-Hispanic individuals and Hispanic individuals. And so while our initial goals were let's bring Black individuals up and let's bring Hispanic individuals up, our now moving on goal is to close the gap between Black and white individuals and Hispanic and non-Hispanic individuals.
Got it. Now, I wouldn't be doing my job as the host of Bright Spots, which is essentially a layman term for positive deviance, to ask you this question. Have you ever looked at within, let's say, a Black community of the high performers within there, which I'm sure there's got to be a few, maybe not a lot, and compare like what are they doing differently so you can close the gaps between the majority of low performers?
Yeah, I think that we've tried to, one other space that we're moving into is sort of our cancer work and colorectal cancer screening. And so we know that there are inequities even within populations. It's hard to know exactly what is happening in the homes and the lives of every individual, but the other slice that we are taking and thinking about intersectionality is language. So, for example, Black individuals who speak languages other than English have lower screening rates than Black individuals who speak English. And so that will become sort of a focus of ours. So yes, I think we absolutely appreciate there's no race or ethnicity that is a monolith, and we need to dig down into those differences that drive outcomes.
That's great. That's great. Yeah, Chase, whenever you want to come back on with like a update in a year or two, I'd love to have you back on and hear some of these results from all these things that we've just discussed. I guess I want to just close things out because I know we're getting really tight on time here. Are there any future initiatives or areas of focus for Mass General Brigham's health equity efforts that you want to share, and what impacts you're hoping that they may make?
Yeah, so I mentioned just cancer. So, our 4 priority areas right now are hypertension, substance use disorder, maternal care, and then cancer. And so cancer has been the one that has been in sort of a qualitative, like strategic focus. And so now we're moving into implementation. And there, I think what we really need to do, we're using colorectal cancer as sort of our prototype. So screening for colorectal cancer is very inequitable. So we're thinking about patient navigation, right? How do I get you to an individual who can get you what you need, get you the prep, figure out what you're eligible for, and get you the visits to get to colonoscopy screening. So we're really excited about that as an initiative. And then we've got a whole new class of specialty projects that are going to be starting in FY25. And so really excited to see what kind of products they turn out.
All under the colorectal screening?
No, sorry. The specialty is a whole different. So the doula program was one of the specialty initiatives that started in FY21. We now have a new class of 18 new specialty projects in, GI, neurosurgery, all the places that inequities live, to think about inequities in their space and what they can do to improve those gaps.
So that's coming soon. I love that.
Coming soon.
Anything I didn't ask you yet that you wanted me to ask you?
No, I think that you nailed it all. I think just really that notion of social risk care planning, I think, is incredibly important, is understanding the social drivers of health and how we ameliorate them. And that clearly will take some resources.
Let's make that part of the title.
I love it.
I already announced the title for everyone who's listening, but we're going to make it a different title. So when you see it on your podcast app, we'll have social risk planning in there. Where could people find either you, if you want people to find you, some of these initiatives, MGB? Where could you point folks to?
Yeah, so we have a United Against Racism webpage that's available. If you just Google United Against Racism, Mass General Brigham, that's got some information there. We've got a couple of publications that sort of describe the work that we have done. And then there has been some media coverage about some of our various programs. So in the Boston Globe and other outlets and PR that people can turn to, and happy to provide some links as useful.
Right. Yeah, we'll put some links. We'll do some of our searching as well online and provide some links into the description of the show. But yeah, if you put in United Against Racism, it's the first thing that comes up. So really appreciate it. Dr. Bryant, you were great. This was everything I was hoping to be. We've been working on this discussion for a long time, so I'm glad we were able to do it. A quick, so huge thanks. And just a quick message. quick message to everyone listening before you take off. Like, a problem at your organization or in your community may look hopelessly complex, but rather sometimes than looking for that big kind of cover to fill the big hole, use the strategy of looking for bright spots. Use the strategy for looking for bright spots, things that are working well among all the chaos, because these are the tactics that generate progress and maybe even an entire solution strategy to your toughest challenges, like equitable access in healthcare, like how to really effectively leverage social risk care planning. And so I hope you use some of the bright spots and ideas shared today to inspire your thinking, maybe even copy a couple of them or two. We provide this show for you. So remember, this is your Bright Spots in Healthcare podcast. Take care, everyone.